The sound cuts through the emergency department like a blade through silk. A mother's scream, raw and primal, echoing off the sterile white walls. I'm running before my brain fully processes what I've heard. My sneakers squeak against the polished linoleum, the fluorescent lights overhead blurring into streaks of white as I sprint toward Trauma Bay 3. The double doors burst open ahead of me, and a paramedic rushes through, cradling something impossibly small against his chest. Behind him, a woman stumbles in, her face drained of all color, her hands trembling violently at her sides. 18-month-old female, the paramedic shouts, his voice steady despite the chaos. Fall from approximately 8 feet. Unresponsive at the scene. Bradycardic. Respiratory distress. My attending, Dr. Patricia Vance, appears beside me as if materializing from the air itself. Her gray eyes are sharp, focused, already calculating. Get me vitals. Now. The trauma bay erupts into controlled chaos. Nurses swarm the gurney where the paramedic lays the tiny body down. The baby, a girl with dark curls matted against her pale forehead, lies motionless, her chest barely rising. Her lips have a bluish tint that makes my stomach clench. Someone calls out numbers that sound wrong, all wrong. Heart rate, 42. Oxygen saturation, 78%. Blood pressure, 60/40. Doctor. Vance's fingers move to the baby's neck, feeling for a pulse, her face unreadable. She glances at me, and in that single look, I understand. This isn't just a fall. Something else is happening here, something we haven't seen yet. Dr. Reyes, she says, her voice cutting through the noise. Start bagging her, gently. I grab the pediatric bag valve mask, my hand steadier than I feel inside. As I position it over the baby's small face, I catch sight of the mother being held back by security, her voice breaking into sobs that sound like they're tearing her apart from the inside. But what I don't know yet, what none of us know, is that the fall didn't cause this. The baby was already in trouble before she hit the ground. My name is Dr. Noah Reyes, and I've been a resident at Hospital St. Halsted for exactly 4 months and 13 days. Not that I'm counting. Okay, maybe I'm counting. Every shift feels like walking a tightrope between what I learned in textbooks and what actually happens when a human being is bleeding, screaming, or dying in front of you. The theories I memorized for exams don't prepare you for the weight of a stethoscope against your neck, the smell of antiseptic mixed with fear, or the way time seems to both crawl and sprint simultaneously in the emergency department. Hospital St. Halsted sits on the edge of a mid-sized city in the Midwest, a sprawling complex of glass and brick that serves a diverse population. We see everything here: farm accidents, drug overdoses, heart attacks, strokes, and the occasional mystery that keeps the entire department guessing until lab results come back or someone has a breakthrough. It's a teaching hospital, which means residents like me are constantly shadowing attendings like Dr. Vance, trying to absorb decades of experience through osmosis. The building itself is relatively new, constructed just 7 years ago with state-of-the-art equipment and thoughtful design. Large windows let natural light flood into the waiting areas, supposedly to reduce patient anxiety. The emergency department entrance features automatic doors that slide open with a soft whoosh, leading into a triage area where nurses perform initial assessments. Beyond that lies the main ED, a maze of examination rooms, procedure spaces, and those critical trauma bays where the most serious cases land. I grew up in Houston, Texas, the son of immigrants who sacrificed everything so I could have opportunities they never had. My father worked construction, coming home every night with cement dust in his hair and exhaustion etched into his face. My mother cleaned houses, her hands rough from chemicals and hard work. They never complained. They just worked, saved, and pushed me toward education with a fierceness that shaped every decision I've ever made. Medical school was brutal. 4 years of memorizing anatomical structures, biochemical pathways, disease processes, and drug mechanisms. 4 years of studying until 3 in the morning, surviving on coffee and determination, questioning whether I was smart enough, strong enough, good enough. The debt I accumulated feels astronomical, a number so large it seems almost abstract. But every time I doubted myself, I thought of my parents. I thought of the sacrifices they made, and I pushed through. Residency is different from medical school. In school, you study patients from a distance, analyzing cases that have already been solved, learning from outcomes that have already occurred. In residency, you're in the middle of it. Patients arrive with complaints you have to unravel in real time. There's no answer key in the back of the book, no professor to tell you if you're on the right track. There's only the patient in front of you, their life depending on your ability to think clearly under pressure. Dr. Patricia Vance has been practicing emergency medicine for 23 years. She has silver streaks in her dark hair that she doesn't bother to hide, and a reputation for being both brilliant and brutally honest. Some residents are terrified of her. I'm somewhere between terrified and in awe. She doesn't tolerate incompetence, but she rewards effort and genuine curiosity. When she asks you a question, she's not testing you to make you look stupid. She's testing you because she actually wants to know if you're thinking. I've learned more from Dr. Vance in 4 months than I learned in entire semesters of medical school. She teaches by doing, by showing, by questioning. She'll ask me to examine a patient and then quiz me afterward. What did you notice about their breathing pattern? Did you see how their neck veins were distended? What does that tell you about their cardiovascular status? She forces me to observe, to synthesize, to think like a clinician rather than just regurgitate facts. This morning started like most Tuesday mornings, early. The sun was just beginning to paint the sky in shades of pink and orange when I arrived at the hospital at 6 a.m., clutching a coffee from the shop across the street. The emergency department was relatively quiet, that deceptive calm that happens in the hour before the city fully wakes up. A few overnight patients were being discharged, their paperwork rustling in the nurses' station. The overnight resident, Dr. Marcus Chen, looked exhausted but relieved as he gave me the handoff report. "Quiet night," he said, though his eyes suggested he didn't quite believe it. One STEMI went to the cath lab around 2 a.m. A couple of abdominal pains that turned out to be nothing, probably gas and anxiety. Oh, and a guy who swallowed a quarter on a bet. He rubbed his face, the stubble on his chin evidence of the long shift. I swear, the things people do. I smiled, sipping my coffee. "Get some sleep, Marcus. That's the plan." He clapped me on the shoulder and headed for the exit, his white coat wrinkled and stained with what I hoped was just coffee. The emergency department at St. Halstead is designed in a hub-and-spoke model. The central nurses' station sits in the middle, surrounded by a dozen patient rooms radiating outward like the petals of a flower. Computer workstations line the central hub, where doctors and nurses document encounters, review lab results, and coordinate care. Large monitors display real-time information about each patient, their location, chief complaint, assigned physician, and how long they've been waiting. It's a system designed for efficiency, though on busy days it still feels like barely controlled chaos. Trauma bays, rooms equipped for the most critical cases, are located near the ambulance entrance, their doors painted red for easy identification. Each bay contains more equipment than some small hospitals: ventilators, cardiac monitors, ultrasound machines, crash carts loaded with emergency medications, and surgical instruments for procedures that can't wait. The walls are a pale green, a color supposedly chosen to reduce anxiety, though I'm not sure it works. The constant hum of monitors, the beeping of IV pumps, the shuffling of feet, it all blends into a kind of medical symphony that you eventually learn to tune out. Dr. Vance arrived at 7 sharp, as she always does. She walked past me with a nod, her white coat spotless, a tablet tucked under her arm. Her movements are always purposeful, never rushed, but conveying urgency through sheer focus. "Morning, Reyes. Ready for whatever comes through those doors?" "Always," I said, though we both knew that was a lie. You're never really ready. For the first hour, we handled routine cases. A teenager with a sprained ankle from basketball. He'd landed wrong after attempting a dunk he had no business trying. The ankle was swollen, tender, but the x-rays showed no fracture. I wrapped it in a compression bandage, gave him crutches, and sent him home with instructions to rest, ice, elevate. Standard stuff. Next came an elderly man with chest pain that turned out to be severe indigestion. His EKG showed normal sinus rhythm, no signs of ischemia, and his cardiac enzymes were negative. He'd eaten a massive meal of spicy foods the night before and had spent the early morning hours convinced he was dying. We gave him an antacid cocktail, and within 20 minutes, he felt significantly better. Relief flooded his face, followed quickly by embarrassment. "Don't feel bad," I told him. "Chest pain is nothing to mess around with. You did the right thing coming in." Then there was a woman in her 30s with a migraine so intense she was vomiting. The fluorescent lights in the ED made her wince, and she kept her eyes closed as I took her history. She'd been getting migraines for years, she said, but this one was different, more severe, more persistent. I ordered IV fluids and anti-nausea medication, checked her neurological exam, and presented the case to Dr. Vance. "Good start, Reyes," she said, after I correctly identified early signs of dehydration in the migraine patient. But don't forget to check her medication list. Some triptans can cause rebound headaches if overused. I made a mental note, adding it to the growing catalog of clinical pearls I was accumulating. Medicine, I was learning, is as much about pattern recognition as it is about knowledge. You see enough cases, and the patterns start to emerge. A constellation of symptoms begins to suggest specific diagnoses, but every so often you see something that doesn't fit any pattern you've learned. That's when things get interesting and terrifying. The nursing staff at St. Halstead is exceptional. Sarah, the senior nurse I work with most often, has 20 years of experience and an almost telepathic ability to anticipate what a doctor needs before they ask for it. She's in her 40s, with kind eyes and a no-nonsense attitude that patients respond to. Miguel, the respiratory therapist, is younger but equally competent, always ready with a ventilator or nebulizer treatment when needed. Then there's Jennifer, the charge nurse, who manages the entire department with the organizational skills of a military general. Around 8:30, the department started to fill up. Morning is when people realize they can't ignore their symptoms any longer, or when parents bring in children who spiked fevers overnight. The waiting room filled with the usual mix of anxiety and impatience, the air thick with the smell of hand sanitizer and worry. People sat in uncomfortable plastic chairs, some reading magazines, others staring at their phones, all of them hoping their name would be called soon. I was reviewing labs on a patient with suspected kidney stones, a middle-aged man who'd been writhing in pain, rating it a 10 out of 10, when the call came over the radio. The distinctive crackle of static, followed by the dispatcher's voice. Incoming trauma. 18-month-old female, fall from height. ETA 3 minutes. Dr. Vance's head snapped up from the chart she was reviewing. Reyes with me. Trauma Bay 3. We moved quickly, her stride purposeful but not rushed. I've noticed that about Dr. Vance. She never runs unless absolutely necessary. Running causes panic, she once told me. Panic causes mistakes. Move with purpose, not panic. As we walked toward the trauma bay, she spoke, her voice low enough that only I could hear. Pediatric traumas are different. Children have tremendous physiological reserve. They can compensate for blood loss and shock far longer than adults. Their vital signs might look stable right up until the moment they crash. When a child decompensates, it happens fast. We need to be ready for anything. I nodded, my heart rate picking up despite my efforts to stay calm. I'd assisted in a few pediatric cases before, but each one felt like stepping onto new ground. Kids aren't just small adults. Their bodies respond differently to injury, illness, medication. Their blood volumes are smaller, so even minor bleeding can become critical. Their airways are narrower, more prone to obstruction. The margin for error is terrifyingly small. When we reached the trauma bay, nurses were already preparing. Sarah was laying out pediatric airway equipment, tiny endotracheal tubes, pediatric laryngoscope blades, small bag valve masks. Miguel was checking the ventilator settings, adjusting them for a child's smaller lung volumes. Jennifer was preparing IV catheters in various sizes, knowing we'd need vascular access immediately. Everything moved with a practiced efficiency that came from years of doing this dance. The room smelled of sterile equipment and cleaning solution. The overhead lights were bright, almost harsh, designed to illuminate every detail during procedures. The cardiac monitor sat silent for now, waiting for a patient to connect to. The crash cart stood ready in the corner, its drawers labeled with color-coded tags indicating different medications and equipment. History? Dr. Vance asked as the paramedics burst through the doors. The lead paramedic, a man named Dave who I'd seen dozens of times, spoke rapidly while maintaining his grip on the small bundle in his arms. Mom says the baby was standing on a chair in the kitchen, reaching for something on the counter. She turned away for a second to put dishes in the sink, heard a crash, found the baby on the floor, unresponsive. No witnesses to the actual fall. Kitchen is tile floor, approximately 8-foot fall from chair to ground. Dave gently transferred the baby to our gurney, and I got my first clear look at her. She was tiny, dressed in pink pajamas with little elephants printed on them. Her dark curls were tangled, and there was a small scratch on her forehead, probably from the impact. But what struck me most was her color. She was pale, almost gray, with a bluish tint around her lips. Her breathing was shallow, irregular. My mind immediately started running through the differential diagnosis, the list of possible explanations for her condition. Head trauma was obvious. A fall from 8 feet could cause skull fractures, epidural hematoma, subdural bleeding, cerebral contusion. But it could also cause cervical spine injuries, so we'd need to maintain spinal precautions. Internal injuries were possible, liver or spleen lacerations, though less common in children due to their flexible rib cages. Pneumothorax maybe if she'd landed on her chest. Dr. Reyes, Dr. Vance's voice cut through my mental checklist. Start bagging her, gently. I grabbed the pediatric bag valve mask, my hands steadier than I felt inside. The mask was sized for a toddler, small enough to fit properly over her nose and mouth. I positioned it carefully, creating a seal, then squeezed the bag. Her small chest rose as air entered her lungs. I established a rhythm, one squeeze every 3 seconds, watching her chest rise and fall, monitoring for any resistance that might indicate airway obstruction. As I worked, Sarah was establishing IV access, sliding a small catheter into a vein on Sophia's hand. Miguel stood ready with the ventilator if we needed to intubate. Jennifer was already drawing blood for labs, complete blood count, comprehensive metabolic panel, coagulation studies, type and cross in case we needed transfusion. But as I bagged Sophia, something nagged at me. Something didn't quite fit. Dr. Vance's hands moved with practiced precision as she performed the primary survey, the systematic approach to trauma assessment that we'd all memorized in medical school. Airway, securing, breathing, assisted ventilation provided, circulation, weak peripheral pulses, delayed capillary refill greater than 3 seconds. Disability, GCS of 5. She paused, her fingers gently palpating Sophia's small body. Exposure, no obvious external trauma besides the small forehead abrasion. I continued bagging Sophia, feeling the slight resistance of her small lungs with each squeeze. Her chest rose and fell with my compressions, but the oxygen saturation wasn't improving as quickly as it should. The monitor above the bed blinked red numbers at us. Oxygen sat still hovering at 81%, despite supplemental oxygen at 100% concentration. That was wrong. If her airway was patent and we were ventilating her properly, her oxygen saturation should be climbing toward the 90s at least. The fact that it wasn't suggested either severe lung injury, which we'd need a chest x-ray to confirm, or something else was preventing adequate oxygenation. Heart rate's improving, Sarah called out, her eyes on the monitor. 58, 62, 65, that was good news. Bradycardia, abnormally slow heart rate, in a child is an ominous sign, often indicating severe hypoxia or impending cardiac arrest. The fact that Sophia's heart rate was responding to our interventions suggested her heart was still capable of functioning if we could just fix whatever was wrong. Dr. Vance pressed gently on Sophia's abdomen, starting at the right upper quadrant and working her way around. When she reached the left upper quadrant, just below the ribs, I saw Sophia's face grimace, a reflexive response even in her unconscious state. Dr. Vance's expression tightened almost imperceptibly. Rigid abdomen, distension, left upper quadrant tenderness. She looked up at the team. Possible splenic injury with internal bleeding. That made sense for an abdominal trauma. The spleen, located in the left upper abdomen, is one of the most commonly injured organs in blunt trauma. If it had ruptured or lacerated, Sophia could be bleeding internally, which would explain her poor perfusion and cardiovascular compromise. But something still bothered me. I'd seen splenic injuries before. Not many, but enough to have some reference point. This felt different. Sophia's level of cardiovascular compromise seemed disproportionate to an 8-foot fall. Children are remarkably resilient. Their organs are cushioned by flexible cartilage and resilient tissue. An 8-foot fall onto tile would certainly hurt, might cause fractures or mild organ injury, but this degree of shock seemed excessive. Dr. Vance caught my eye. "What are you thinking, Reyes?" It was a test, but also a genuine question. She wanted to know if I was seeing what she was seeing. I took a breath, organizing my thoughts. The mechanism doesn't match the presentation. An 8-foot fall in a healthy toddler could cause head trauma, fractures, maybe a small splenic laceration. But this level of cardiovascular compromise, heart rate in the 40s at the scene, persistent hypoxia despite intervention, the degree of abdominal distension, it seems like... I hesitated, not wanting to be wrong, not wanting to sound like I was overreaching. It seems like something was already happening before the fall. Dr. Vance nodded slowly, a gesture that might have been approval. Go on. What makes you think that? I gestured toward Sophia while maintaining my bagging rhythm. The fall history doesn't explain all of her symptoms. If she fell and hit her spleen, we'd expect localized trauma. But her overall condition, The profound shock, the difficulty oxygenating, suggests a more systemic process. And I paused, noticing something I hadn't fully registered before. Her abdomen looks more distended than I'd expect from acute bleeding. It's not just fluid. It looks like it's been developing over time. Excellent observation, Dr. Vance said. She turned to the trauma bay entrance where the mother stood, now flanked by a social worker named Patricia and a security guard who was there more for support than restraint. The mother, I could see her name on the wristband someone had placed on her, Elena Martinez, looked devastated, her mascara streaking down her cheeks, her hands clutching a small pink blanket that probably belonged to Sophia. Ms. Martinez, Dr. Vance said, her voice firm but not unkind. I need you to tell me everything that happened this morning, everything before the fall. Don't leave anything out, even if it seems unimportant. Elena's voice came out in broken fragments, each word seeming to cost her tremendous effort. She was fine, playing in the living room with her toys, happy, laughing. Then she came into the kitchen where I was cleaning up from breakfast. She wanted cookies. I keep them on the counter in a jar, and she knows where they are. She climbed up on the chair. She does that sometimes, she's so independent. And I turned to put dishes in the sink. I was only turned away for maybe 10 seconds. Then I heard the crash and turned around and her voice broke completely. She was on the floor, not moving. I screamed. I picked her up and she wasn't breathing right, and I called 911. Dr. Vance listened intently, her face neutral, absorbing every detail. Before that, how has she been feeling the past few days? Any fever, vomiting, changes in appetite or behavior? Elena's eyes widened slightly, as if surprised by the question. She's been a little cranky the past week, maybe a little more tired than usual. Not eating as much, but I thought maybe she was teething or fighting off a cold. Kids get sick all the time, right? Nothing serious. Why are you asking me this? What does that have to do with the fall? Dr. Vance didn't answer directly. Instead, she turned back to the team, her mind clearly working through possibilities. I want a CT scan of the head and abdomen. Full trauma panel including coagulation studies. Type and cross for 4 units of packed red blood cells. And someone page pediatrics. I need their most experienced attending down here now. The urgency in her voice sent a ripple through the room. Sarah immediately picked up the phone to call the pediatric department. Miguel double-checked the ventilator settings, preparing for possible intubation. Jennifer started preparing additional IV access points in case we needed to run multiple medications or blood products simultaneously. This wasn't standard protocol for a simple fall. This was the response to something complex, something potentially catastrophic. I kept bagging Sophia, watching her small face. Her eyelids fluttered occasionally, a sign that she might be regaining some level of consciousness, but she didn't fully wake. The oxygen saturation had finally crept up to 86%, but it was taking tremendous work to keep her there. Each squeeze of the bag required just the right amount of pressure. Too little and she wouldn't ventilate adequately. Too much and I could damage her delicate lungs. Dr. Reyes, Sarah said, catching my attention. She held up a syringe filled with dark blood, darker than I expected, almost burgundy in color. Blood draws done, sending to lab stat. How long should I tell them? Tell them 15 minutes or less, Dr. Vance said. This is priority 1. Sarah nodded and hurried toward the pneumatic tube system that would send the blood samples directly to the laboratory. I looked more carefully at Sophia's exposed skin, now that we'd removed most of her clothing for the examination. At first, I'd been focused on her breathing, her circulation, her overall stability. But now, with slightly more time to observe, I noticed something I'd initially overlooked. Scattered across her chest and arms were tiny red spots, petechiae. They looked almost like a fine rash, but I knew they weren't. Petechiae are small hemorrhages under the skin, indicating that tiny blood vessels are breaking and leaking blood into the surrounding tissue. That wasn't from a fall. That was from something inside her body going very wrong. Dr. Vance, I said, my voice sharper than I intended. She has petechiae, scattered across her chest and arms. Dr. Vance's head whipped around with an urgency I rarely saw from her. She leaned in, examining Sophia's skin closely under the bright overhead lights. Her jaw tightened, and I saw something flash across her face. Not quite fear, but deep concern. Get me a platelet count. I want that result in the next 10 minutes, not 15. Jennifer immediately grabbed the phone, calling the lab directly. This is the ED. We have a critical pediatric trauma. We need platelet count in 10 minutes. Yes, I understand it's busy. I need it in 10 minutes. The room seemed to hold its breath. Petechiae combined with a distended abdomen, cardiovascular compromise, And now the possibility of splenic injury pointed towards something systemic, something related to blood, to clotting, to the most fundamental processes that keep a body functioning. But what? What could cause a previously healthy toddler to develop such profound problems so quickly? Dr. Vance turned back to Elena, who was watching all of this with growing horror. Ms. Martinez, has Sophia had any recent illnesses? Any infections? Even minor ones like a cold or stomach bug? Elena thought hard, her brow furrowed. Maybe 2 weeks ago, she had a runny nose. Nothing major. It cleared up on its own in a few days. That's it. A viral infection 2 weeks ago. That was potentially significant. Certain viruses can trigger immune responses that affect platelet production or survival. But we needed more information. Any family history of bleeding disorders? Dr. Vance continued. Does anyone in your family bruise easily, have prolonged bleeding from cuts, or have problems with blood clotting? No, Elena said firmly. Nothing like that. We're healthy. Sophia's always been healthy. Please, what's happening to my baby? Dr. Vance's expression softened slightly. We're figuring that out right now. I promise you, we're doing everything we can. The CT scanner was ready, and we carefully transported Sophia, maintaining her airway support throughout the journey. I stayed with her, my hands keeping rhythm with the bag, while Dr. Vance accompanied us, her eyes never leaving the monitor that displayed Sophia's vital signs. Elena followed behind, escorted by Patricia the social worker, her footsteps echoing in the wide corridor that connected the emergency department to the radiology suite. The hospital corridors at this hour were busy, nurses moving between floors, food service workers delivering breakfast trays, environmental services staff cleaning rooms. Everyone gave our little procession a wide berth, recognizing a critical transport when they saw one. Inside the CT suite, the massive machine hummed to life with a low mechanical sound. The room was cold, kept at a constant temperature to preserve the sensitive equipment. We positioned Sophia on the narrow table that would slide into the circular opening of the scanner. I stepped back behind the protective barrier, a thick wall embedded with lead to block radiation, but I kept my eyes on Sophia through the observation window. Miguel took over the bagging temporarily while I moved to safety. The table slid smoothly into the circular opening, and the scanner began its work. Invisible X-rays rotated around Sophia's small body, creating cross-sectional images that would reveal what was happening inside her. The machine made a rhythmic whirring sound as it worked, each rotation capturing another thin slice of data. 3 minutes later, the images appeared on the screen. Dr. Vance stood beside the radiologist on duty, Dr. Michael Kim, a man with wire-rimmed glasses and a perpetually serious expression. I watched their faces as they scrolled through the scans, reading their reactions. Dr. Kim's frown deepened with each image. Dr. Vance's lips pressed into a thin line. No skull fracture, Dr. Kim said, his voice clinical and measured. Minimal cerebral edema. No evidence of epidural or subdural hematoma. Brain looks structurally intact. That was good news. Head trauma wasn't the primary problem. But look at the abdomen. He clicked to a different series of images. Sophia's internal organs appeared in shades of gray, each structure distinct and identifiable if you knew what you were looking at. Dr. Kim pointed to an area in the left upper quadrant. Free fluid in the abdomen. Significant amount. I'd estimate at least 200 milliliters, possibly more. And the spleen, he zoomed in on the image. There's a large subcapsular hematoma. The capsule appears to be ruptured. Active bleeding likely. My stomach sank. A ruptured spleen would cause internal bleeding, which would explain the distended abdomen and the cardiovascular compromise we'd been seeing, but something still didn't add up. What about the size of the spleen? Dr. Vance asked, leaning closer to the screen. Dr. Kim measured it using the computer's software tools. Significantly enlarged, approximately 8 centimeters in length. Normal for this age would be about 5 centimeters. There it was. The spleen wasn't just injured, it was enlarged before the injury occurred. That changed everything. A normal spleen might withstand a fall like Sophia's with minimal damage. An enlarged spleen is fragile, engorged with blood, its capsule stretched thin. Even a minor impact can cause it to rupture. Dr. Vance turned to me. What causes splenic enlargement in an 18-month-old? My mind raced through the differential diagnosis I'd memorized countless times. Infection is most common. Mononucleosis in older kids and adults, though that's rare in toddlers. Other viral infections can cause transient enlargement. Malaria in endemic areas, though that's unlikely here. Hematological disorders, sickle cell disease can cause splenic enlargement. though usually it causes splenic atrophy over time. Lymphoproliferative disorders, storage diseases. I paused, the implications of that last category sinking in. Or malignancy. Leukemia can cause massive splenic enlargement. Dr. Vance nodded slowly. Or thrombocytopenia with splenic sequestration. If her platelets are low and her spleen is enlarged, it creates a vicious cycle. The spleen holds onto platelets, making the thrombocytopenia worse, which makes her prone to bleeding, which enlarges the spleen further. We transported Sophia back to the trauma bay immediately, and as we did, my phone buzzed with a message from the lab. I read it quickly, and my blood went cold. Platelet count is 28,000, I said quietly. Normal for a child Sophia's age was between 150 and 400,000. 28,000 meant Sophia's blood couldn't clot properly. Any injury, even a minor one, could cause uncontrolled bleeding, and she currently had a ruptured spleen bleeding into her abdomen. Dr. Vance's expression darkened, confirming what we both knew. She didn't fall and then start bleeding. She was already bleeding internally. The bleeding made her weak and dizzy. That's why she fell. The fall just made everything catastrophically worse. Back in the trauma bay, the atmosphere shifted from urgent to critical. The pediatric attending arrived. Dr. Linda Ochoa, a woman in her 50s with kind eyes and a reputation for solving the unsolvable. She'd been the head of pediatrics at St. Halsted for almost a decade, and I'd heard other residents speak of her with the kind of reverence usually reserved for legendary figures. Dr. Ochoa reviewed the CT images on the computer screen at the nurse's station, her reading glasses perched on her nose. She studied the scans carefully, zooming in on the spleen, examining the free fluid in the abdomen, checking the other organs for any abnormalities. Then she pulled up Sophia's lab results, the platelet count, the hemoglobin, the white blood cell count. Her expression grew more concerned with each piece of data she reviewed. This child has severe thrombocytopenia, splenic enlargement, and a ruptured spleen causing active hemorrhage, she said quietly, speaking to Dr. Vance and me in tones low enough that Elena wouldn't overhear from where she stood near Sophia's bedside. The question is why? Is this immune thrombocytopenic purpura, leukemia, bone marrow failure, an atypical presentation of something else entirely? How do we find out? I asked. We need more blood work, Dr. Ochoa said. Complete metabolic panel, LDH, uric acid, peripheral blood smear for manual review, coagulation studies beyond just platelets, and ultimately, she's going to need a bone marrow biopsy. But first, she looked at the CT images again. First, we need to stop the bleeding. She can't survive much longer with an actively hemorrhaging spleen and platelets this low. Dr. Vance nodded. Surgery? I'll call Dr. Holloway now. He's the best pediatric surgeon we have. Dr. N. Ochoa pulled out her phone and stepped away to make the call. I returned to Sophia's bedside. Sarah had taken over the bagging temporarily, giving my hands a rest. Sophia's color remained poor, that grayish-blue tint that indicated inadequate oxygen delivery to tissues. Her abdomen was visibly distended now, swollen with the blood that was accumulating inside her peritoneal cavity. Elena stood nearby, one hand covering her mouth, the other clutching that pink blanket. She looked like she wanted to touch her daughter but was afraid that any contact might cause more harm. Why is her stomach so big? She asked, her voice barely above a whisper. Dr. Vance stepped over to explain. Sophia is bleeding internally, into her abdomen. That's what's causing the swelling. We're going to take her to surgery to stop the bleeding. Surgery? Elena's voice cracked. She's just a baby. Can she survive surgery? Children are remarkably resilient, Dr. Vance said. And the surgeon we're calling is one of the best in the region. But I won't lie to you, Ms. Martinez. Sophia is very sick. The fall revealed a serious underlying problem. We don't know yet what's causing it, but we're going to find out. What kind of problem? Elena demanded, her voice rising with barely contained panic. What's wrong with her blood? Why can't it clot? She was fine last week. She was fine yesterday. How can everything change so fast? Those were excellent questions. The same questions we were asking ourselves. How does a healthy toddler develop life-threatening thrombocytopenia seemingly overnight? The answer, I was beginning to understand, was that it probably didn't happen overnight. Sophia's condition had likely been developing for weeks, maybe even months, with subtle symptoms that were easy to dismiss. Fatigue, decreased appetite, maybe some bruising that Elena attributed to normal toddler clumsiness. The fall hadn't caused the problem. It had revealed it in the most dramatic way possible. Dr. Holloway arrived within 20 minutes, still in his scrubs from a previous surgery. He was a tall man in his early 50s with graying hair and steady hands that had performed countless pediatric operations. He reviewed the CT images quickly, asked a few pointed questions about Sophia's vital signs and lab values, and made his decision. "We need to take her to the OR now," he said. "The spleen has to come out. She'll live without it. She'll be more susceptible to certain infections and will need vaccinations, but she'll survive. If we leave it in, she's going to exsanguinate." Exsanguinate, medical terminology for bleeding to death. The operating room team mobilized with impressive speed. Within 10 minutes, Sophia was being transported through the hospital corridors toward the surgical suite. I followed alongside the gurney, still maintaining her airway with the bag valve mask. Dr. Vance walked on the other side, monitoring the portable cardiac monitor that displayed Sophia's vital signs. Elena was given just a moment to lean down and kiss her daughter's forehead before we took her away. "I love you, baby," she whispered. "I'll be right here when you wake up, I promise." The operating room at St. Halsted is a place of controlled sterility and focused intensity. I'd been in the OR before during my surgical rotations in medical school, but always as a distant observer, someone holding retractors or watching from the gallery above. This time, Dr. Vance had arranged for me to scrub in alongside the surgical team. "You were there from the beginning," she said. "You should see this through." I scrubbed at the large sinks outside the OR, using the special antimicrobial soap and the prescribed technique I'd learned years ago. Nails first, then each finger, then hands, then forearms, everything timed precisely. The water was warm, almost hot, and the scrubbing was meditative in its repetitiveness. Inside the OR, Sophia lay on the operating table, intubated now with a proper endotracheal tube rather than the bag valve mask I'd been using. The anesthesiologist, Dr. Patel, stood at the head of the table, monitoring her vital signs with intense concentration. Monitors beeped rhythmically, displaying heart rate, blood pressure, oxygen saturation, end-tidal CO2, and numerous other parameters. "Platelets are going in now," Dr. Patel said, adjusting the IV pump that was infusing platelet concentrate. "But she's going to need more. Multiple units. Her coagulation factors are barely holding." Dr. Holloway positioned his instruments on the sterile field. Scalpels, forceps, retractors, clamps, all arranged with surgical precision. "Then we work fast. Let's see what we're dealing with." The incision was precise. A clean line across Sophia's small abdomen, following natural skin lines to minimize scarring. Dr. Holloway worked with practiced efficiency, cutting through skin, then subcutaneous tissue, then the muscular layers of the abdominal wall. As he carefully opened the peritoneal cavity, blood welled up immediately. Dark, venous blood that shouldn't be there in such quantity. "Suction," Dr. Holloway said calmly. The surgical tech activated the suction device, and the blood was drawn away into a collection canister, revealing the organs beneath. Sophia's spleen came into view, and even to my inexperienced eyes, it looked wrong. "Jesus," Dr. Holloway muttered under his breath. "This isn't just from the fall. Look at this tissue." I leaned in, careful not to contaminate the sterile field. The spleen was massively enlarged, easily double its normal size for a toddler. Its surface was mottled with dark purple hemorrhages, areas where blood vessels had ruptured, and blood had seeped into the organ's substance. The capsule, the thin membrane that normally holds the organ together, had multiple tears. Some were clearly fresh with active bleeding, but others looked older, partially healed, suggesting this had been an ongoing process. "This spleen was already compromised before the trauma," Dr. Holloway said, his voice grim. "The fall just pushed it over the edge. There's no saving it. I'm taking it out." The splenectomy was complex and painstaking. Dr. Holloway worked methodically, identifying and tying off the blood vessels that supplied the spleen, the splenic artery and vein, which branched off from major vessels in the abdomen. Each vessel had to be carefully isolated, clamped, tied with surgical suture, and then cut. The process required absolute precision. One slip, one tear in the wrong place, and Sophia could bleed out on the table. I assisted where I could, holding retractors to keep the surgical field open, using the suction device to clear blood so Dr. Holloway could see what he was doing, cutting sutures after he tied knots. My hands remained steady, but my mind was racing. I couldn't stop thinking about what that diseased spleen meant for Sophia's future. "Dr. Reyes," Dr. Holloway said at one point, "what are you thinking about right now?" The question surprised me. "I'm thinking about the differential diagnosis. What could cause this degree of splenic pathology in a child this young? Good, he said, not looking up from his work. Never stop thinking about the why. The mechanics of surgery are important, but understanding the disease process is what makes you a true physician. The splenectomy took 45 minutes from incision to removal. When Dr. Holloway finally extracted the damaged organ, he placed it carefully in a specimen container filled with formalin preservative. It looked even worse outside the body than it had inside. Too large, too dark, covered in those disturbing purple hemorrhages, parts of it almost black with necrotic tissue. Send this to pathology stat, Dr. Holloway instructed the scrub nurse. I want a full workup. Histology, immunohistochemistry, flow cytometry if possible. We need to know what we're dealing with. You think it's malignancy? I asked quietly. Dr. Holloway glanced at me as he began closing the layers of Sophia's abdomen. Could be leukemia with splenic infiltration. Could be lymphoma, though that's rare at this age. Could be a severe autoimmune process, ITP with massive splenic involvement. Could be something metabolic or genetic that we haven't even considered. That's why we test everything. After closing the abdomen, layer by layer, each suture precise and carefully placed, we transported Sophia to the pediatric intensive care unit, the PICU at St. Halsted is located on the 4th floor, a specialized unit where the sickest children receive round-the-clock monitoring and care. The unit is designed to be as child-friendly as possible while still functioning as an intensive care environment. The walls are painted in soft, calming colors, blues and greens that suggest ocean and sky. Murals of friendly animals decorate the hallways. Each patient room has a window, and natural light is prioritized whenever possible. But underneath the cheerful veneer, this is a place of life and death medicine. Sophia was placed in a private room, her bed surrounded by sophisticated monitoring equipment. Multiple IV pumps delivered medications, blood products to replace what she'd lost, antibiotics to prevent infection, now that she no longer had a spleen to help fight certain bacteria, medications to support her blood pressure and heart function. Elena was allowed in once Sophia was settled and stable. She stood at the bedside, one hand hovering over her daughter's hand, still afraid to actually touch her. Sophia looked tiny in the hospital bed, surrounded by all the equipment. The endotracheal tube was still in place, connected to a ventilator that breathed for her with mechanical precision. Monitoring leads covered her chest. IVs ran into both arms. Is she going to wake up? Elena asked, her voice raw from crying. Dr. Ochoa, who had come up to the PICU to continue managing Sophia's case, explained gently, the anesthesia will wear off over the next few hours, but we're keeping her sedated for now to help her body heal and to keep her comfortable while she's on the ventilator. The machine is doing the work of breathing for her, giving her lungs a rest while her body recovers from the surgery and the blood loss. And then what? Elena asked. Once she's stable, what happens then? Dr. Ochoa hesitated, choosing her words carefully. That depends on what the tests show us. We've sent extensive blood work to look for leukemia, genetic disorders, autoimmune conditions. We've sent the spleen to pathology for detailed analysis. Once we have those results, and it may take a day or two for some of them, we'll know what we're dealing with and what treatment options are available. Treatment options? Elena's voice broke. You mean like chemotherapy? Like cancer treatment? Possibly, Dr. Ochoa said honestly. But let's not get ahead of ourselves. We need the results first. Right now, Sophia is stable. She made it through surgery. That's a huge step. But I could see in Dr. Ochoa's eyes that she was already suspecting what we would find. The rest of that day passed in a strange blur of activity and waiting. I rotated back to the emergency department to complete my shift, handling other patients. A man with chest pain who turned out to have costochondritis, inflammation of the cartilage connecting ribs to the sternum. A woman with a urinary tract infection who needed antibiotics. A teenager with a broken wrist from skateboarding who needed reduction and casting. But my mind kept drifting back to Sophia. Between patients, I checked her chart in the computer system, reviewing her vital signs, her lab values, her progress notes from the PQ team. Her blood pressure had stabilized after the surgery. Her heart rate was normal for her age, but her platelet count, even after transfusion, remained dangerously low, only 35,000. Around 5 in the evening, my phone buzzed with a notification. Preliminary lab results available for patient Martinez Sophia. I practically ran to the nearest computer workstation and pulled up her chart. The hematology report was extensive, filled with technical terminology and numerical values. But a few key findings jumped out immediately. White blood cell count, 24,000. That was elevated, nearly double the upper limit of normal for a toddler. By itself, an elevated white count could indicate infection or inflammation, but combined with everything else we'd seen, hemoglobin, 6.2 gdl, severely low, confirming significant blood loss. She'd received transfusions during surgery, which had temporarily improved this number, but it had dropped again. Platelets, 35,000, still critically low despite transfusion, but it was the peripheral blood smear that made my stomach drop. The hematologist who'd reviewed it had written a detailed comment. Peripheral blood shows numerous blast cells, approximately 40% of white blood cells. Blasts are large with high nuclear to cytoplasmic ratio, prominent nucleoli, and scant cytoplasm. Morphology consistent with lymphoblasts. Recommend urgent bone marrow biopsy for definitive diagnosis. Findings highly suspicious for acute lymphoblastic leukemia. Blast cells. Immature white blood cells that had no business being in the bloodstream of a healthy child. They belonged in the bone marrow, where blood cells develop and mature before being released into circulation. When you find blasts in the peripheral blood, especially in significant numbers, it almost always means one thing: leukemia. My hands trembled slightly as I picked up the phone to call Dr. Ochoa. She answered immediately, as if she'd been waiting for this call. "Did you see the blood smear results?" I asked. "I did," she said, her voice heavy with the weight of what those results meant. "I've already scheduled a bone marrow biopsy for tomorrow morning. That's the only way to confirm the diagnosis definitively and to determine the specific subtype of leukemia." "How do you tell a mother that her child has cancer?" I asked quietly. Dr. Ochoa was silent for a moment. "Honestly, compassionately, and with hope. Because despite how terrible this diagnosis is, pediatric all has one of the highest cure rates of any childhood cancer. Most children beat this disease. Sophia has a real chance." That evening, Dr. Ochoa sat down with Elena in one of the private consultation rooms adjacent to the PCU. I wasn't present for that conversation. It wasn't my place, but I later learned what was said. Dr. Ochoa explained the blood smear findings, what blast cells meant, what the next steps would be. Elena had broken down, understandably, sobbing for her daughter, for the innocence lost, for the long battle ahead. But Elena was also stronger than I think anyone expected. After the initial shock, she began asking questions. What's the treatment? What's the success rate? How long will it take? What will Sophia's life be like during treatment? Can I stay with her? Those questions, Dr. Ochoa later told me, were encouraging. They meant Elena was already shifting from despair to determination. She was preparing to fight. I stayed at the hospital late that night, well past the end of my shift. I couldn't bring myself to leave, not with Sophia's case unresolved, not without knowing the final confirmation. Around 9 p.m., I went up to the PICU to check on her one more time. Sophia was still sedated, still on the ventilator, but her vital signs were stable. The monitors showed a regular heart rhythm, adequate blood pressure, good oxygen saturation. Her body, at least for now, was holding on. Elena sat beside the bed, holding Sophia's small hand in both of hers. She was singing softly in Spanish, a lullaby, I realized, the kind a mother sings to her child at bedtime. The melody was beautiful and heartbreaking. I stood in the doorway, not wanting to interrupt. After a moment, Elena noticed me and paused her singing. "Dr. Reyes, I just wanted to check on how she's doing," I said quietly. "She's a fighter," Elena said, her voice steady despite the tears on her cheeks. "Just like her mama. We're going to get through this." "I believe you will," I said, and I meant it. The next morning, I arrived at the hospital before dawn again. Sleep had been elusive, my mind unable to stop replaying every moment of Sophia's case, analyzing every decision, wondering if there was something we could have done differently or faster. But the truth was, we'd done everything right. We'd questioned the narrative, looked beyond the obvious, found the hidden disease. The bone marrow biopsy was scheduled for 8 a.m. In the pediatric procedure room, a specialized space designed to minimize trauma for young patients while still allowing for sterile technique. Dr. Ochoa would perform the procedure with assistance from the PICU team. I wasn't scheduled to be present. Bone marrow biopsies are specialized procedures beyond my current training level. But Dr. Ochoa had invited me to observe. "You've been part of Sophia's case from the very beginning," she said. "You should see it through to the diagnosis." Sophia was given additional sedation to keep her comfortable during the procedure. She remained intubated, her breathing still supported by the ventilator, as Dr. Ochoa prepared the biopsy site on her right hip. The posterior iliac crest, The curved bone at the top of the pelvis is the standard location for bone marrow sampling in children. It provides good access to marrow-rich bone while avoiding major blood vessels and nerves. Dr. Ochoa explained each step as she worked, partly for my benefit, partly for the PICU nurses assisting her. We use a special bone marrow biopsy needle to penetrate through the outer cortex of the bone into the marrow space, she said, her gloved hands steady and sure. It's one of the most direct ways to assess what's happening at the source of blood cell production. The bone marrow biopsy needle was thicker and sturdier than regular needles, designed to punch through hard bone. Dr. Ochoa palpated Sophia's hip, identifying the anatomical landmarks by feel. She positioned the needle carefully, angled it just right, and applied firm, controlled pressure. There was a subtle crunch, the sound of the needle penetrating the outer layer of bone, the cortex. Sophia, deeply sedated, didn't react. Dr. Ochoa advanced the needle further, pushing through the cortex into the medullary cavity where the marrow resided. Then she attached a large syringe and drew back the plunger with steady force. Dark red marrow filled the syringe, a thick, viscous fluid that looked almost like blood, but with a different consistency. The first sample is for aspiration, Dr. Ochoa explained. We'll make slides from this to examine the cellular composition immediately. She withdrew several more samples, placing them in different tubes for various tests. Flow cytometry to identify specific cell markers, cytogenetics to look for chromosomal abnormalities, molecular testing for genetic mutations. Then she removed the aspiration needle and inserted a different one, a core biopsy needle designed to extract a small cylinder of bone with intact marrow architecture. This would allow the pathologist to see not just individual cells, but how those cells were organized and distributed within the bone marrow. That's it, Dr. Ochoa said, withdrawing the needle and applying firm pressure to the biopsy site to prevent bleeding. Now we wait for pathology to work their magic. But the wait wasn't long. Dr. Graham, the hematopathologist, was standing by to perform an immediate preliminary review of the bone marrow aspirate smears. He took the slides Dr. Ochoa had prepared and disappeared into the pathology department's microscopy suite. 45 minutes later, my phone rang. It was Dr. Ochoa. Can you come to the PICU? We have the preliminary results. I practically sprinted to the elevator. When I arrived at the PICU, Dr. Ochoa was standing at the nurse's station, staring at a computer screen. Her expression was grim. It's acute lymphoblastic leukemia, she said quietly as I approached. B-cell all, to be specific. The blast cells in her marrow are over 90%. That's why her normal blood cells, her platelets, her red blood cells, eventually her functional white blood cells, were being crowded out. The leukemia cells were taking over her bone marrow, leaving no room for healthy cells. I felt like I'd been punched in the stomach, even though I'd been expecting this diagnosis. Knowing it was coming didn't make it any easier. What's the prognosis? Ochoa took a slow breath, organizing her thoughts. With modern treatment protocols, the cure rate for pediatric B-cell ALL is around 90%. It's actually one of the most treatable childhood cancers we have. But, and this is important, it requires intensive chemotherapy. The treatment protocol typically lasts 2.5 to 3 years. The first month is induction therapy, trying to put her into remission. Then consolidation therapy to eliminate any remaining leukemia cells. Then maintenance therapy that continues for years. What does that mean for Sophia? For her quality of life during treatment? She'll lose her hair, Dr. Ochoa said honestly. She'll be immunosuppressed, vulnerable to infections. She'll have periods of severe nausea, fatigue, pain. She'll miss out on normal toddler activities for extended periods. It's going to be brutal, not just for her, but for Elena, but... She paused, meeting my eyes. But most children get through it. Most children survive and go on to live normal, healthy lives. Sophia has a real chance. Does Elena know yet? I'm about to tell her. Dr. Ochoa stood. Do you want to be there? I nodded, not trusting my voice. We walked together to the small family consultation room. Elena was already there, sitting on the edge of a chair, her hands clasped so tightly her knuckles were white. She looked up when we entered, and I saw in her eyes that she already knew. Some part of her had been preparing for this moment. Ms. Martinez, Dr. Ochoa began, sitting down across from her, maintaining eye contact. The bone marrow biopsy results came back. Sophia has acute lymphoblastic leukemia. It's a cancer of the blood and bone marrow, where immature white blood cells multiply uncontrollably and crowd out healthy blood cells. Elena's hands flew to her mouth, but she didn't cry. Not yet. She was holding herself together with visible effort. Cancer, she whispered. My baby has cancer. Yes, Dr. Ochoa confirmed gently. But I need you to hear this. ALL is one of the most treatable childhood cancers. With aggressive chemotherapy, the cure rate is approximately 90%. 9 out of 10 children beat this disease and go into permanent remission. Chemotherapy, Elena repeated, her voice hollow. She's only 18 months old. How can her little body survive chemotherapy? Children actually tolerate chemotherapy better than adults do in many ways, Dr. Ochoa explained. Their bodies are resilient, their cells regenerate quickly. The treatment protocol for pediatric ALL is well established. It's been refined over decades and we know what works. Sophia will need to stay in the hospital for the first phase of treatment, probably 4 to 6 weeks. Then she'll continue treatment as an outpatient for approximately 2.5 years. 2.5 years? The reality of it seemed to hit Elena all at once. 2.5 years of poison being put into my daughter's body? I know it sounds overwhelming, Dr. Ochoa said, but we take it one step at a time, one phase at a time. Right now, our immediate goal is induction, getting Sophia into remission as quickly as possible. Once we achieve that, we move to the next phase. You don't have to think about the full 2.5 years right now. Just focus on the next step. Elena was crying now, silent tears streaming down her face. Why did this happen? What did I do wrong? Was it something in our house? Something she ate? Did I miss something I should have seen? No, Dr. Ochoa said firmly, leaning forward. This is not your fault. Childhood leukemia happens because of random genetic mutations in developing blood cells. It's not caused by anything you did or didn't do. It's not environmental. It's not from food or cleaning products or anything else. It's random, unfair, and absolutely not your fault. But she was fine, Elena sobbed. Just last week she was playing, laughing, being a normal toddler. How did everything change so fast? It probably didn't change as fast as it seemed, Dr. Ochoa said gently. Looking back, you said she'd been more tired, eating less, a bit cranky. Those were probably early symptoms. The leukemia was likely developing for weeks or even months. But the symptoms were subtle enough that you attributed them to normal childhood things. Teething, a cold, growing pains. No parent would have recognized those as signs of cancer. The fall, Elena said suddenly, looking up. If she hadn't fallen, if I hadn't brought her to the emergency room that day, would we have found this? Dr. Ochoa and I exchanged glances. Eventually, Dr. Ochoa said, but it might have been later. Sophia's platelet count was so low that she would have had another bleeding episode eventually. Maybe a nosebleed that wouldn't stop, or severe bruising, or something else that would have brought her to medical attention. But the fall happened when it did, and it led us to discover the leukemia before it progressed even further. In a strange way, the fall might have saved her life by getting her to the hospital when we could still intervene aggressively. Elena absorbed this, her expression shifting through grief, fear, and finally settling into something like determination. What do we do now? Now, Dr. Ochoa said, we fight. We start chemotherapy as soon as Sophia is strong enough, probably in the next day or two. We hit this cancer hard and fast, and you... She reached across and placed her hand over Elena's. You stay strong for your daughter. She's going to need you. Can I see her? Elena asked. Of course. She's still sedated, but you can sit with her. Talk to her. She can hear your voice, even if she doesn't respond. That connection is important. We all stood and walked back to Sophia's room in the PICU. Sophia lay still in her bed, the ventilator breathing for her with mechanical precision, monitors displaying her vital signs in steady rhythms. She looked impossibly small, impossibly fragile. Elena sat down in the chair beside the bed and took Sophia's hand again. She leaned close and began whispering in Spanish, prayers probably, or promises, or both, words meant for her daughter alone. I stepped back into the hallway, giving them privacy. Dr. Vance was waiting there, leaning against the wall. She must have heard about the diagnosis. Hell of a case for your 4th month of residency, she said quietly. Yeah, I managed, my voice rough. You handled it well, Reyes. You stayed curious. You questioned the story when something didn't fit. You noticed the petechiae, the abdominal distension that seemed disproportionate to the mechanism of injury. You didn't stop at the easy answer. She paused. That's what separates adequate doctors from exceptional ones. The willingness to dig deeper, to question, to look for what's hiding beneath the surface. But I didn't diagnose the leukemia, I protested. The blood smear did. The biopsy did. You found the clues that led us there, Dr. Vance corrected. Without your observations, we might have treated Sophia for traumatic injuries and sent her home once she stabilized, and then, a week later, she might have had another catastrophic bleed at home where we couldn't save her. Your attention to detail, your clinical judgment, helped save her life. I wanted to believe her, but looking at Sophia, knowing what she was facing, years of chemotherapy, hair loss, nausea, weakness, the fear and pain, it felt like a hollow victory. We'd saved her life, yes, but the battle was just beginning. The days that followed became a carefully orchestrated dance of preparation, treatment, and family support. Sophia remained in the PICU for another 48 hours, during which time she was gradually weaned from the ventilator. When she finally breathed on her own again, it felt like a small miracle, even though we all knew the much larger battle ahead. On the third day after her surgery, Sophia was transferred from the PICU to the pediatric oncology unit on the 5th floor. The oncology unit at St. Halstead is both a medical facility and an attempt at creating a child-friendly environment. The walls are painted in cheerful colors, sunny yellows, ocean blues, grass greens. Murals of friendly animals and fantasy scenes decorate the corridors. The playroom is stocked with toys, games, and art supplies. There's even a small library filled with children's books in multiple languages. But underneath the cheerful veneer, this is a place where children face mortality. It's where they lose their hair, where they vomit from chemotherapy, where they cry from bone pain and needle sticks. It's where some children recover and go home, and where others, tragically, don't. Sophia's room had a large window overlooking the hospital's garden. Elena had already begun personalizing the space. A stuffed elephant sat on the windowsill. Family photos were taped to the wall, and that pink blanket I'd first seen in the emergency department was draped over the chair where Elena slept each night. The oncology team, led by Dr. Marianne Cross, took over Sophia's care. Dr. Cross was everything you'd want in a pediatric oncologist. Brilliant, compassionate, and realistic without being discouraging. She sat down with Elena and carefully outlined the treatment protocol. We use a standardized approach for pediatric B-cell ALL, Dr. Cross explained, showing Elena a thick binder that contained the treatment protocol. It's divided into phases. First is induction, which lasts about a month. The goal is to kill as many leukemia cells as possible and put Sophia into remission. What does induction involve? Elena asked, her notepad ready. She'd started taking notes on everything, determined to understand every aspect of Sophia's treatment. Multiple chemotherapy drugs given in combination, Dr. Cross said. Vincristine, daunorubicin, L-asparaginase, and steroids. Each drug attacks the cancer cells in different ways. We also give intrathecal chemotherapy. That means injecting chemotherapy directly into the spinal fluid to prevent leukemia cells from hiding in the central nervous system. Elena's face paled. That sounds like a lot of poison going into her body. It is aggressive, Dr. Cross acknowledged. And there will be side effects: hair loss, nausea, increased infection risk, fatigue. But this intensity is what gives us that 90% cure rate. We've learned over decades of research that hitting the cancer hard and fast from the beginning gives children the best chance of survival. And if she goes into remission, Elena asked, then we move to consolidation therapy, more chemotherapy to eliminate any remaining cancer cells we can't detect. Then maintenance therapy, which is lower intensity but continues for about 2 years. During maintenance, she'll be able to be home most of the time, living a more normal life, but still coming in regularly for treatment and monitoring. Elena nodded slowly, processing the information. When do we start? Tomorrow morning, Dr. Cross said. I know that seems fast, but with leukemia, time matters. The sooner we start treatment, the better her chances. That night, I visited Sophia's room after my shift ended. I wasn't directly involved in her care anymore. She was firmly under the oncology team's management, but I couldn't stop thinking about her. Sophia was awake now, sitting up in bed with Elena beside her. She looked more alert than she had in days, though her skin still had that pallor that worried me. Dr. Reyes, Elena said when she saw me. Look, Sophia, it's one of the doctors who helped you. Sophia looked at me with big brown eyes, curious but cautious. She was holding her stuffed elephant, clutching it tightly. How are you feeling, Sophia? I asked, even though I knew she was too young to really answer. She's been asking for juice, Elena said, and she wanted to watch cartoons this afternoon. Those seem like good signs, right? Definitely, I agreed. It means her body is starting to recover from the surgery and the acute phase of the illness. Elena stood and walked over to where I stood near the door. She kept her voice low so Sophia wouldn't hear. Dr. Cross says they start chemotherapy tomorrow. I'm terrified. That's completely understandable, I said. Chemotherapy is scary, especially when it's your child receiving it. What if she can't tolerate it? What if it's too much for her little body? The oncology team will monitor her constantly, I assured her. They're experts at managing side effects and adjusting doses if needed. And children really do tolerate chemotherapy better than adults in many ways. Their bodies are resilient, their cells regenerate quickly. Elena wiped at her eyes. I keep thinking about that morning. If I had just watched her more carefully, if I hadn't turned away. Ms. Martinez, I interrupted gently. The fall didn't cause the leukemia. The leukemia caused the fall. If anything, that fall saved Sophia's life by bringing her to the hospital when we could still intervene. You did everything right. She nodded, but I could see the guilt still weighing on her. That kind of guilt doesn't dissolve easily, no matter how many times people tell you it's not your fault. The next morning, I checked Sophia's chart electronically. The chemotherapy had begun. The oncology team had administered the first doses of vincristine and daunorubicin, along with dexamethasone, a steroid that would help kill leukemia cells, but would also make Sophia irritable and hungry. Over the next few days, I continued checking her progress through the computer system, watching as her white blood cell count began to drop. A sign that the chemotherapy was killing off the leukemia cells, but also killing off healthy white blood cells in the process. 2 weeks into treatment, Sophia developed a fever, a common and dangerous complication in cancer patients whose immune systems are compromised by chemotherapy. Fever in a neutropenic patient, someone with dangerously low white blood cell counts, is a medical emergency. Infections that would be minor annoyances in healthy people can be deadly when the body has no white blood cells to fight them. Sophia was started on broad-spectrum antibiotics immediately, covering the most likely bacterial culprits. Blood cultures were drawn. Chest x-rays were taken to look for pneumonia. For 48 hours, the oncology team watched her closely, adjusting antibiotics based on her response. Finally, the fever broke, and the cultures came back negative, probably a viral infection that her compromised immune system struggled to handle. Throughout all of this, Elena never left. She slept in that chair in Sophia's room, ate meals from the hospital cafeteria, and maintained a constant vigil. Family members came and went. Sophia's grandmother brought home-cooked food, an aunt helped with laundry and errands, but Elena was the constant presence, the anchor keeping Sophia tethered to hope. 4 weeks after the chemotherapy began, Sophia underwent another bone marrow biopsy. This one would determine whether the induction therapy had worked, whether she'd achieved remission. The entire oncology team seemed to hold their breath waiting for the results. I was in the emergency department when Dr. Cross called me. Dr. Reyes, I thought you'd want to know. Sophia's in remission. No detectable leukemia cells in her bone marrow. I felt tears prick my eyes, surprising myself with the intensity of my emotional response. That's incredible news. It is, Dr. Cross agreed. It's exactly what we hoped for. Now we move on to consolidation therapy. She's not cured yet. We have a long way to go. But this is a huge milestone. I asked if I could visit Sophia to share in the good news, and Dr. Cross said Elena had specifically requested that I come by. When I arrived at Sophia's room that evening, the atmosphere was transformed. Balloons floated near the ceiling, gifts from the nursing staff. A cake sat on the windowsill, also from the nurses. Elena was actually smiling, the first genuine smile I'd seen on her face since this nightmare began. Sophia herself looked different too. Her hair had started to fall out from the chemotherapy, and Elena had shaved what remained, replacing it with a collection of colorful bandanas and hats. Today, Sophia wore a bright pink bandana decorated with butterflies. She'd lost weight, her cheeks less full than before, but her eyes were brighter. She was sitting up in bed, playing with her elephant, making it walk across the blanket. Dr. Reyes, Elena called out when she saw me. We did it. We beat the first part. I heard, I said, unable to keep the smile off my face. Congratulations, Sophia. You're a fighter. Sophia looked up at me and shyly waved. It was a small gesture, but it felt monumental. This child who'd been unconscious and dying just weeks ago, now alert and responding and fighting. Dr. Cross says we still have a long road ahead, Elena said, her smile fading slightly. But she also said most kids who achieve remission this quickly stay in remission. That's good, right? That's very good, I confirmed. It means Sophia's cancer is responding exactly the way we hoped it would to the treatment. Over the following months, I continued to check on Sophia periodically. though my role in her care had ended. She progressed through consolidation therapy, more intensive chemotherapy designed to eliminate any remaining leukemia cells. She had more fevers, more hospital admissions, more days of feeling terrible. But she also had good days, days when she smiled and played and acted like the toddler she was supposed to be. Elena remained strong throughout, though I knew it was costing her. She'd taken a leave of absence from her job to focus entirely on Sophia's care. Family and friends had organized fundraisers to help with medical bills. The social work team at St. Halsted had connected Elena with support groups for parents of children with cancer, and she'd found community there. Other mothers and fathers who understood what she was going through in ways that nobody else could. 6 months after Sophia's diagnosis, she transitioned to maintenance therapy. This phase would last for approximately 2 years, but was much less intensive. She could be home most of the time, attending regular appointments for chemotherapy and monitoring, but otherwise living a relatively normal life. I ran into Elena and Sophia in the hospital lobby one afternoon, about 7 months after that initial emergency department visit. They were there for a routine oncology appointment. Sophia was walking now. Not just walking, but running ahead of her mother, full of energy. Her hair was growing back, short and dark and curly. She wore pink sneakers that lit up when she walked. "Dr. Reyes!" Elena called out, hurrying to catch up with Sophia. I knelt down to Sophia's level. "Hi, Sophia. Do you remember me?" She studied me carefully, then shook her head. She'd been unconscious for most of our initial interactions, so that wasn't surprising. "Dr. Reyes was one of the first doctors who helped you when you were sick," Elena explained to her daughter. Then, to me, "She's doing so well. Her blood counts are great. Dr. Cross says she's responding perfectly to the maintenance therapy." "That's wonderful news," I said genuinely. "You know what's strange?" Elena said. "I keep thinking about that day. The fall. If it hadn't happened, if I hadn't brought her to the emergency room." She trailed off, shaking her head. "The fall saved her life. You saved her life," I corrected, "by recognizing something was wrong and getting her help immediately." Elena smiled sadly. "I guess we both did our part. The whole team did. Thank you, Dr. Reyes, for questioning, for looking deeper, for not just accepting the obvious answer." After they left for their appointment, I stood in the lobby for a moment, thinking about Sophia's journey. From that terrifying morning in the trauma bay to now, running through the hospital lobby with the energy and joy of any healthy child. Medicine couldn't cure everything, couldn't save everyone, but sometimes, when we paid attention, when we questioned, when we fought hard, we could turn tragedy into triumph. It's been almost a year now since Sofia Martinez fell from that kitchen chair and changed my understanding of what it means to be a doctor. I'm still a resident at St. Halsted, still learning, still making mistakes, and occasionally getting things right. But Sophia's case taught me lessons I carry with me every single day. Last week, I got a notification through the hospital's electronic system. Sophia had completed her maintenance chemotherapy. She was officially done with treatment. The oncology team would continue to monitor her closely. Cancer surveillance, checking regularly to ensure the leukemia didn't return, but the active treatment was finished. Dr. Vance found me in the emergency department that afternoon. She didn't say anything, just handed me a card. Inside was a photo of Sophia, now 3 years old, wearing a pink dress and a huge smile, her curly hair long enough to put into pigtails. Beside the photo was a handwritten note from Elena. "Dr. Reyes and Dr. Vance, thank you for saving my daughter's life. Thank you for seeing what others might have missed. Thank you for fighting for her when she couldn't fight for herself. Sophia is thriving now, happy, healthy, and full of life. She doesn't remember being sick, and that feels like a blessing. But I will never forget what you did for us. With eternal gratitude, Elena and Sofia Martinez." I read the note 3 times, my throat tight with emotion. Dr. Vance watched me quietly, a slight smile on her face. "Cases like this don't come along every day," she said finally. "But when they do, they remind us why we do this work, why we put ourselves through the exhausting shifts, the emotional toll, the constant pressure. Because sometimes, if we're paying attention, if we're thinking critically, if we're willing to question the obvious answer, sometimes we can actually save a life." "I'll never forget this case," I said. "Good," Dr. Vance replied. "Hold on to it. Let it guide you when you're faced with the next patient who doesn't quite fit the expected pattern. Let it remind you that the most important answers are often hidden beneath the surface." I've thought a lot about Sophia's case in the months since, about how easily we could have missed the diagnosis if we'd simply accepted the fall as the primary cause of her symptoms. about how many other children might present with injuries or accidents that are actually symptoms of underlying diseases, about the importance of maintaining curiosity even, especially when the obvious answer seems sufficient. Medicine is full of these moments, I'm learning. Moments where the surface explanation conceals a deeper truth. Patients who present with chest pain but actually have anxiety disorders, abdominal pain that turns out to be cardiac disease, falls that reveal cancer. Our job isn't to accept the first explanation that makes sense. Our job is to keep asking why, to look for inconsistencies, to notice the details that don't quite fit. It's exhausting work, mentally and emotionally. Every patient becomes a puzzle to solve, and we don't always have all the pieces. But when we get it right, when we catch the disease that's hiding, when we save the life that might otherwise have been lost, it makes every sleepless night, every difficult decision, every moment of doubt worth it. Sophia's fall didn't cause her leukemia, but it revealed it. And in revealing it, the fall gave us the opportunity to fight back, to intervene, to save her life. Sometimes tragedy and salvation are intertwined in ways we can't predict or control. Sometimes the worst moments become catalysts for survival. As I continue through my residency, I carry Sophia's story with me. When I'm tired, when I'm tempted to accept the easy answer, when I start to doubt whether all this effort matters, I think of a little girl in pink sneakers running through a hospital lobby, alive because someone bothered to question, to look deeper, to care enough to see what was hidden beneath the surface. That's what medicine is, at its core. Not just knowledge and technique, though those matter. Not just protocols and procedures, though those are essential. At its core, medicine is about paying attention. It's about caring enough to see the whole patient, not just their presenting complaint. It's about having the courage to say, something doesn't fit here, even when you can't immediately explain what's wrong. Sophia taught me that. A toddler who couldn't speak, who was unconscious for our first encounter, who had no idea she was teaching me one of the most important lessons of my medical career. She taught me that the answer isn't always obvious, that sometimes the injury isn't the problem. It's just the symptom that reveals the real problem. And she taught me something else, something perhaps even more important, that hope and resilience can overcome even the darkest diagnoses. That a 90% cure rate means 9 families who get to keep their children, 9 children who grow up to have full lives, 9 miracles that happen because medicine, imperfect, difficult, exhausting medicine, actually works. 2 days ago, I was working a shift in the emergency department when a father brought in his 5-year-old son. The boy had fallen off his bicycle and hit his head. Standard pediatric trauma. We see them all the time. I performed the usual assessment, checked his pupils, examined his scalp for lacerations, evaluated his neurological status. But then I noticed something. The boy had unusual bruising on his arms and legs. Not just the fresh bruises you'd expect from a bike crash, but older bruises in various stages of healing. Yellowing patches mixed with purple-blue marks. Too many bruises for a simple fall. I felt that familiar prickle of suspicion. Something doesn't fit. I ordered a complete blood count along with the routine head CT, and when the results came back, the platelet count was low. Not as catastrophically low as Sophia's had been, but low enough to warrant investigation. The head CT was normal, but the blood work told a different story. That boy is now in the care of the hematology team, undergoing evaluation for a possible bleeding disorder. The bike fall didn't cause his problems. It revealed them. Just like Sophia's kitchen fall revealed her leukemia. This is what I've learned. Accidents are often not what they seem. A fall might be a symptom rather than a cause. An injury might reveal a disease that's been hiding. And our job, the job of doctors, of healers, of people who've chosen to dedicate our lives to understanding the human body, is to look beyond the obvious, to question the narrative, to find the truth hiding beneath the surface. Sophia Martinez is alive today because we did that, because we questioned, because we looked deeper, because we refused to accept the easy answer when something didn't quite fit. And somewhere in this city, a little girl in pink sneakers is running, playing, laughing, living the life she almost lost. She doesn't know that she changed me, that her case reshaped how I approach every patient. But I know, and I'll carry her lesson with me for the rest of my career. Sometimes the fall doesn't cause the problem. Sometimes the fall just reveals what was already there, hiding in plain sight, waiting to be discovered by someone who cares enough to look.